I think we'll move to one of the most important lectures today. دكتور فارس مسنات استشاري أمراض المعدية from South Dakota. راح يناقش معنا the treatment. I think this is going to be one of the most interactive sessions كمان. Dr. Faris, with no delays, thank you so much and please go ahead.
اوكي مساء الخير، شكرا جزيلا. سامعيني كويس؟
نعم دكتور فارس، صوتك.
اوكي شكرا جزيلا. alright. بس اضبط الويندو هون. alright, thank you. So مساء الخير جميعا في الأردن. Discuss the treatment of SARS-CoV2 infections and what we know so far. And I emphasize on so far because this is a field that keeps changing almost on daily basis as new trials are being conducted. Okay, خلينا نشوف. All right. أنا طبعا خريج الأردن وحاليا بشتغل في ساوث داكوتا. خلينا نتحدث عن and I'm an infectious disease specialist. So before I jump to drugs, let's principles of management. وزملائي تحدثوا عن هاي في المحاضرات الأخرى, but I'll come across them real quick. Initially with history, it's close to impossible to confirm a diagnosis just based on history. The signs and symptoms are relatively non-specific. The total loss of taste and smell seems to be the most specific symptom, and most patients regain that with time, although some do not. في مرضى بعد شهرين أو 3 أشهر لسه ما استرجعوا حاسة الشم والتذوق. There is for diagnostics نسمع عن ال PCR testing. The sensitivity seems to be about 80%. Why do we have some false negative results? Many times it has to do with the test itself. Sometimes they do a nasal swab rather than a nasopharyngeal swab. So if they do a nasopharyngeal swab in somebody who is symptomatic, usually the sensitivity is pretty good. Many times it's even over 80%. However, if the patient is asymptomatic, we tend to have a relatively higher false negative result. There's the antigen test that we are hearing about, and they started implying it. It's helpful in when you are testing a large number of people before, for example, a flight or a big activity going on, or in the school system, if you want to test hundreds or thousands of students every week or so. This is a decent test. Just to emphasize the sensitivity, so far what's reported is 97%, but we had a problem with influenza antigen test where the sensitivity was reported to be around 97%, but it turned out to be around 70%. So I wouldn't trust the antigen testing very well. So you tend to have high false negative results with the antigen testing. So it's just something to watch for, because we're going to have a lot of antigen testing. Oh, excuse me. Okay, here we go. We're going to have a lot of antigen testing coming up over the next few months. So it's just something to watch for. Regarding admissions, زملائي تحدثوا عن هاي النقطة. Try to manage patients at home if possible. If they start becoming hypoxic, depending on what's available, you can try to manage at home, but many patients will need to be admitted. Regarding diagnostic, we talked about PCR. A lot of things are non-specific, including leukopenia, elevated CRP, bilateral lung infiltrates, ground glass opacities. All these are non-specific and depend on the pretest probability. For example, right now, مثلا عمان في حالات كثير من الكوفيد إذا واحد إجا ب progressive shortness of breath and they have ground glass opacities on a CT scan, most likely it's COVID-19. but always consider other other differential diagnoses. Just quickly about risk factors, and risk factors might be an important part in determining admissions and treatments. And let's say you have a specific treatment like Remdesivir available in small amounts or in limited supply. You might want to use the risk factors to stratify who's going to receive it, for example. So age is still the most important risk factor. Despite all the other risk factors, age still remains the most important risk factor. Immune-compromised status, organ transplant patients. HIV seems to be a risk factor. However, well-controlled HIV with a suppressed viral load or undetectable viral load does not seem to be a major risk factor. Other immune deficiencies, such as people who are normally on prednisone for 20 milligrams more than 1 month. برضو مرضى COPD، مرضى الأزمة، cystic fibrosis, pulmonary fibrosis، مرضى القلب، coronary artery disease, hypertension, cancer, obesity, and morbid obesity. أي واحد body mass index more than 40, that seems to be a significant risk factor as well. Diabetes mellitus، احنا بولايتي بساوث داكوتا كان عندنا outbreak، كان عندنا مصنع و1000 شخص أصيبوا في الكورونا بشهر 4، وهذا كله خلال عين فقط. فمعظم العمال في ذاك المصنع كانوا من دول أخرى، وكان صار لهم بالولايات المتحدة أكثر من سنة أو سنتين. في بعض منهم ما شاف دكتور إطلاقا، فاكتشفنا إنه عدد كبير منهم كان عنده سكري، كان عنده دايابيتس وهم مش عارفين. وزي ما بتعرفوا hypertension, diabetes, they can go undiagnosed for several years. خصوصا إذا بتشوف مريض مثلا بالثلاثينات وعنده severe COVID-19, check the hemoglobin A1C or at least check serum glucose، لأنه you can diagnose a lot of cases of diabetes with COVID-19 presentation، خصوصا عند الناس اللي ما بيشوفوا دكتور بشكل مستمر. Chronic kidney disease, liver disease, neurological disease. Okay. One thing about smoking, always ask about الأرجيلة. Okay. Move. All right. So inpatient management. Let's see, how do I go to the next slide?
Click annotation, Faris. You got start annotation. This is a frequent problem. You have to unlock annotation.
Okay.
And then move.
Do you know? Do I go save annotation?
الدكتور يعطيك العافيه. معك محمود. ابسط شيء ممكن تعمله انك تعمل كلوز للفيرتيكال تول بار اللي على يسار شاشتك.
Okay. Yeah, I close it. Okay, it's working now. شكرا. Okay, inpatient management. So when we talk about drugs and drugs that are possibly in the pipeline to treat, بدنا نفهم شوي على الكوفيد 19 على الcourse of the illness. إذا بتطلع this is day 0 since symptoms started. So before day 0 already المريض صار عنده infection. This is the pre-symptomatic phase. This is the virus. This is the زي ما شايفين viral load هون اللي هو this turquoise line, the green line. This is the viral load in the blood. كم كمية الفيروس الموجودة in the blood or in the respiratory tract system. حتى قبل ما تظهر الأعراض الفيروس ببلش يتكاثر، و by the time you have symptoms خلال أول أسبوع هذول الأيام from day -5, 0 to day let's say 7 here, you start having viral replication, and this is the period where when the antivirals started, if possible. If you have any tool to suppress the viral replication, this is at least theoretically the most beneficial period. هلا معظم المرضى بعد الأسبوع الأول أعراضهم تتحسن، لكن المرضى those who develop severe illness and critical illness, usually they start developing that during the second week. So that's where you have to watch for this is where anti-inflammatory drugs might be extremely helpful. So steroids, possibly interleukin-6 inhibitors, etc. So hospitalization, most people who develop severe illness, usually they don't have these severe symptoms during the first week of illness. Okay. Principles of management. If you want to use antibiotics, paracetamol is generally preferred over non-steroidal anti-inflammatory drugs. If you remember early on, with COVID-19, the WHO had a statement warning against NSAIDs like ibuprofen or naproxen. However, they retracted that statement. There's no good evidence that non-steroidals are harmful. لكن كثير مرضى الكوفيد 19 عندهم renal disease, coronary artery disease. There's an increased risk of acute renal failure. So preferably try to avoid using them. But if you have to, then you can use them. Paracetamol is still preferable. Avoid nebulized medications زي ما تحدثوا زملائي due to the risk of aerosolization. Regarding ACE inhibitors and angiotensin receptor blockers, if a patient is already on an ACE inhibitor, do not discontinue those drugs. If for whatever reason you have to start them for hypertension or other issues, preferably use other drugs. But if you absolutely have to use them, you can start them. But the main point, do not discontinue them just for COVID-19 at this point. Regarding statins, معظم المرضى بيكونوا على statin already. They have coronary artery disease or dyslipidemia. You don't have to discontinue those drugs. كثير من المرضى بيكون عندهم elevation of LFTs upon admission. Due to the illness itself, you don't have to stop the statins. It's unlikely to be a cause of the transaminitis unless they were recently started as an outpatient for whatever reason. في جزء من المرضى, the organ transplant patients, it's always best to involve the transplant physician. Or a nephrologist if it's kidney transplant, or hepatologist, etc. But some basic concept is to try to discontinue mycophenolate. Trade name Myfortic or Celcept. However, cyclosporin and tacrolimus, these are calcineurin inhibitors, and they inhibit interleukin 1 and interleukin 6. إذا بنرجع للجراف هون, interleukin 1 and interleukin 6 are major players in the development of ARDS. So preferably try to continue these drugs. Now, it's a theoretical advantage to keep them going, but at least don't stop these first. Start with mycophenolate if possible. If the transplant is recent, it might be very challenging to discontinue any drug or lower the dose. And that's where it might be helpful to consult with the transplant physician. So always weigh the risk of rejection versus infection. Okay, let's talk about steroids. So we had the recovery trial. I think it was published in June or July. In the beginning of COVID, in March, at least in the United States, in March and April, there was some controversy about steroids. There were some recommendations to avoid use because they delay viral clearance. Some recommendations for using them, especially in ARDS. But this trial was extremely helpful. It involved a large number of patients, 11,000 patients. They were either randomized to dexamethasone or standard care. Some of them received other treatments, like I think hydroxychloroquine. Remdesivir was not widely available by that time. I think only 3 or 4 patients in the whole study received remdesivir. I think a total of 5, 2, and 3. So basically, almost nobody got remdesivir. The patients who are in the steroid group received at least 1 dose of dexamethasone, 6 milligrams. So some patients received 1 dose only. However, the median duration of treatment was 7 days. Those in the steroid group. So I'll just jump to the conclusions. Mortality at 28 days was significantly lower in the dexamethasone group than in the usual care group. So it reduced mortality. However, there was a trend towards the greatest benefits in those who were receiving invasive mechanical ventilation. The steroids improved mortality among patients receiving invasive ventilation and in those receiving oxygen without invasive ventilation. So anybody requiring oxygen of any sort had improved mortality. However, those who did not receive any respiratory support, who did not receive any oxygen, there was no benefit of dexamethasone. In fact, patients did worse. The patients who received dexamethasone had a shorter duration of hospitalization. This is patients with mechanical ventilation. They had the highest benefits. This is among all participants. This is among patients who received oxygen only without mechanical ventilation. They also had the benefit. But those with no oxygen received, they did worse. This is a mortality and dexamethasone. So patients who do not need oxygen try to avoid using steroids. Those who require oxygen then start steroids, preferably dexamethasone. So the dose was 6 milligrams daily for 10 days or until discharge, whichever is shorter. Sometimes we keep it for total duration of 10 days. So it's not very clear exactly what's the perfect duration to go for, preferably more than 1 day. Usually the sicker the patient, the longer you have to go. Now, some patients are already on steroids for other reasons, COPD or asthma or some autoimmune disease. So you just have to use a higher dose than 6 milligrams. If dexamethasone is not available, go with alternatives. So you can convert, but the dose of hydrocortisone would be 150 milligrams daily, and you can divide it if you have to, or methylprednisolone 2 milligrams daily, or prednisone 40 milligrams daily. Sometimes patients with severe ALS, you might have to go higher, but اللي أنا بسويه إنه I always talk to the intensivist أو أخصائي الآي سي يو أو أخصائي الرئة to discuss the steroid dose. I would say at least go with 6 milligrams daily. بعض المرضى بيحتاجوا جرعات أكبر. إذا واحد عنده مثلا COPD exacerbation as well, they have some other conditions, you might have to go with higher doses. Monitor for adverse effects, hyperglycemia and infections. وراح نحكي شوي عن infections بعد شوي. Okay, Remdesivir. This is an antiviral drug. Remdesivir طوروه لعلاج الإيبولا وما بيشتغل للإيبولا. لكن اكتشفوا إنه it has some in vitro effects and it seems to be effective for that. So against corona. So it might be helpful here. So after they did some trials, there's a big trial in the US called the ACT trial, ACTT. They studied it in China, however, and it was an underpowered study and did not show any benefit. But basically what we know so far, it's mostly effective for patients requiring low flow supplemental oxygen. Approved for hospitalized children age 12 and adults. The dose given is 200 milligrams on day 1, followed by 100 milligrams daily for 4 days. 10 days, they compared 5 days of treatment versus 10 days. And interestingly, 5 days of treatment showed some benefit, and talk about it. Patients who received 10 days did not do better than placebo, actually. So right now, the recommendation is to do 5 days and not go longer than that. هلا بنشوف مرضى مرات بدخل مريض slightly hypoxic, they need 1 or 2 liters of oxygen. ثاني يوم فجاي على الليبل انه you have to use for 5 days. However, these patients can be discharged before they complete the 5 days. فإذا تحسن they can be discharged. حاليا بالولايات المتحدة ممنوع استعمال as an outpatient. ممنوع مثلا مريض يجي على الطوارئ أو يجي على المستشفى من بيته يأخذ الدواء. He has to be hospitalized. لازم يكون inpatient admitted to receive remdesivir. مع إنه هذا ممكن يتغير بعد فترة. هلا بالرemdesivir avoid if the GFR is less than 30. ليش؟ There's a component within remdesivir called cyclodextran that can cause renal toxicity. So we're very careful using it for GFR below 30. I can't say you should never use it below 30, but you have to be extremely cautious. أنا شخصيا ما استعملته في GFR below 30. Measure ALT, AST. Hepatotoxicity is potentially a risk factor. And I used remdesivir in more than 100 patients. I saw ALT, AST increase to five times the normal level, but it was in a patient who already had very high AST and ALT. And we used it with caution, and but it increased the next day, and we had to hold it for I think a day or two, and then we restarted it. So it seems to be very uncommon to develop hepatitis, but preferably use it monitor the ALT AST closely in these patients. So overall evidence for a clinical benefit is strongest in patients with severe disease who do not require high flow oxygen or ventilatory support. However, you still can use it in these patients. If somebody is already on a mechanical ventilator, it might be beneficial possibly the first day. After that, غالبا مش راح يكون فعال كثير. الرمديسيفير وبرضه غالبا مش راح يكون فعال بالمرضى اللي very early in the infection. Theoretically, it should work, but somebody does not require oxygen supply, it's unlikely to be very helpful. So, and the most importantly, there's no clear evidence that it reduces mortality. However, it can reduce hospital stay and time to recovery. Basically, the way to understand it, it will not prevent someone from dying from COVID-19. However, in those who will not die, they recover faster, and they are able to be discharged sooner and make more hospital beds available. Maybe be less contagious as well. It's possible as well. So له فوائد مش انه له مضار لكن it does not reduce mortality. فهاي شغله مهمه كثير. Safety in pregnant women and children under 12 uncertain لانه بدراسات they excluded these patients. لكن احنا بنحكي مع الاطباء النسائيه بنحكي مع اطباء واستعملوه كثير بهذول المرضى بالاطفال وبالpregnant women and they did not see any complications. فغالبا it is safe in that group. لكن we have to wait for more studies. We have to wait for some confirmation on that. لكن غالبا ما بيعملش مشاكل فظيعه بهذول بالاطفال او بالحوامل. Convalescent plasma. Okay. So okay. Here we go. So it's obtained from individuals who have from COVID-19. It provides passive immunity, passive antibody-based immunity. Basically, is المرضى cannot form their own antibodies against it, against COVID-19. You supply them with the antibodies of somebody else. There's not a strong evidence that it's functional. المشكلة مرات الantibody component within the convalescent plasma is not very high, so it's hit or miss. If you want to consider using it, use it very early. يعني استعملوه لما المريض ممكن for admitted patients if they're on early on in the disease. إذا المريض بلش يدخل ب ARDS or requiring high concentrations of oxygen, it's probably not very helpful. I cannot rule out its use, but we don't have very solid evidence to use it, convalescent plasma. هل هذا البروتين this is the SARS-CoV2 بس بدي أركز شوي على spike protein. This is the target of some treatments that are in development. Spike protein has two units. One unit attaches to the angiotensin receptor enzyme. Other protein allows the fusion of the virus into the host cell. فهو هذا يعني رأس المصايب. فإذا بدنا treatments they are looking at targeted antibodies against the spike protein. على نظريا اذا انت حاربت السبايك بروتين انت راح تحارب الفيروس، راح تمنع الفيوجن of the virus into the host cell. برضو the vaccinations they are mostly targeting the spike protein. We will see. زي ما تعرفوا vaccinations we don't have really good phase 3 trials that are published, although we might see something in the next month. But they usually target the spike protein. We don't have like a live attenuated vaccine in development, as far as I know, because they want to be able to give it to immune compromised patients. So they're targeting the spike protein. So there are, I think, 2 companies that are forming monoclonal antibodies. They work specifically against this spike protein to prevent viral cell entry. هلا they're doing big trials. إذا بتسمع عنهم واحد من Eli Lilly, they have like CoV555 antibody, and Regeneron is the other antibody. This one it's marketed heavily because I think President Trump received a dose of this, and this is the company is marketing this heavily as well. However, the trials on these 2 antibodies are discontinued either due to safety concerns or lack of efficacy. But there are still some other trials that are being continued. There was a trial published in the New England Journal on the like CoV555, and it's relatively disappointing. They used 3 different doses of the antibody, and they seem to reduce the viral loads, which sounds encouraging, might have reduced hospitalization, but it failed in all the intention to treat criteria. So it's really disappointing so far. Now, other treatments. Azithromycin has no benefit and it has potential for harm. We know azithromycin increases the risk of cardiac events in general. And these patients with the coronavirus, many of them have risk factors. Many of them are under cardiopulmonary stress as well. So if you add azithromycin, you increase the risk for arrhythmias. So avoid azithromycin if you can. Secondary bacterial pneumonias are uncommon early on with SARS. The incidence seems to be around 7%. So it's not 0, but most patients will not require antibiotics. Lopinavir, ritonavir, or Kaletra is a trade name. So it's an HIV medication. It has in vitro activity. However, it failed to show any benefit in randomized controlled trials. There was a good trial in the New England Journal in April, I think, and it failed to show any benefit, unfortunately. So we don't use it. Zinc, there's a lot of talk about zinc, a lot of marketing for zinc. What we know is that some people have zinc deficiency, especially alcoholics or people with significant malnutrition. If they have zinc deficiency, there's an increased risk of complications from COVID-19 and viral infections. Have immune deficiency if they have zinc deficiency. لكن إذا واحد يعني باكل مثلا 3 وجبات في اليوم، باكل كميات مختلفة من الطعام، أنواع مختلفة، ما عندوش dietary restrictions، مثلا مش واحد vegan أو واحد alcoholic، غالبية هذول الناس ما عندهمش zinc deficiency or they do not need zinc. So it should not be given routinely. إذا واحد عنده مشاكل بالحصول على الغذاء، مثلا ناس عندهم malnutrition, severe other comorbidities, severe GI illness, maybe GI surgeries, gastric bypass with complications, etc. Maybe they might be deficient in zinc, so it may not hurt. However, it does not help in somebody who does not have nutrition. Vitamin C, no benefit. Really, even in viral infections, influenza, all of these things, it shows no benefit. It can lead to renal stones, and I would recommend against its use. Favipiravir. So in the US, we do not have it. I never used it. I was looking all over the literature. I really did not see a lot of literature on it. It's an RNA polymerase. Might work for influenza. It works for influenza, but for SARS-CoV2, it really doesn't seem to help with moderate or severe disease. It's possible it can help in mild illness. They're doing some trials on it. They use it in Japan. أنا بعرف في السعودية في دول الخليج العربي استعملوه لكن في دراسة في السعودية حاليا عم بيعملوها على الفافيبيرافير. So we'll just have to wait and see the results. Interferons, they work in vitro. Some trials are ongoing. It's a serious, so don't give it unless you have really good evidence that it works. Ivermectin, there were some reports that it has in vitro effect. However, you have to use very, very large doses for it to achieve in vivo effect. They're doing some trials. I know in South America they use it a lot, but who knows? I mean, I would not using it unless you have good evidence. It works against strongyloides, though, and strongyloides, we're starting to see some cases now because of all the steroid using in these patients. Nitazoxanide اسمه تجاري في أمريكا ألينيا أعتقد. There's a study in Brazil that showed some benefit. However, there were so many problems with that study. They did not meet the intention to treat analysis. Many patients were excluded, and في مشاكل كثير بالstudy. It does not seem to help either. So this is an antiparasitic drug. Hydroxychloroquine.
Dr. Faris, 1 more minute.
1 minute?
Yes, لو سمحت, 1 more minute.
Okay. Hydroxychloroquine, it really doesn't work. Just to go, tocilizumab, there's a lot of talk about it. Randomized control trial recently did not show any effect, so I would not. I prefer not to use it unless we have some better evidence. So I'll just jump. I think this is important. So antiviral early on in patients who are not hospitalized, but or hospitalized that do not require treatment, don't give anything, no drugs. Patients who are hospitalized and require supplemental oxygen, usually we do steroids and remdesivir for these two groups. Maybe patients on low flow oxygen, remdesivir only might be helpful. It's not available, so remdesivir and steroids I would recommend for anybody who requires oxygen. Patients on a mechanical ventilator or ECMO, steroids are recommended. Remdesivir probably not helpful. Maybe during the first day of mechanical ventilation it can be helpful. This is just to run a quick case. So somebody with COVID, however, 6 weeks later he returned, and with similar symptoms. We had bilateral lung infiltrates, and a bronchoscopy revealed that he had aspergillosis. So this is something to watch for. This is a case of a girl, 10-year-old girl, who had COVID in May and then came back. It was very mild. Came back 6 weeks later with positive COVID. As we know, the test can remain positive for 3 months. فما في أي فائدة تعيد التست إذا طلع positive. You cannot clear a patient based on a repeat test. So it turned out she was in shock. She had the reduced ejection fraction. Inflammatory markers were elevated, and we diagnosed her with MISC, multi-inflammatory syndrome in children, and the treatment was methylprednisone and IVIG, although they are looking at other treatments that might be helpful. So they're describing MISA in adults. The last slide is the take-home messages. A lot of drugs work in vitro, but they failed in randomized trials. Remdesivir is rarely a life-saving drug. So far, no good evidence it's life-saving. Steroids so far are the only drugs to show a clear mortality benefit in hypoxic patients. The benefit of other anti-inflammatory drugs is not proven yet. Convalescent plasma is probably not very helpful. The benefit of monoclonal antibodies is unclear, but so far data is discouraging. Vitamins or supplements are useless, except in people with deficiencies. Watch for issues, MISC, MISA, fungal infections, pneumocystis pneumonia, tuberculosis reactivation. We always have to consider that. If somebody recovers from COVID and comes back later with the symptoms of respiratory distress and strongyloides. These are references. I encourage everyone to check these references, even if you don't have a subscription to them. Usually the COVID-19 articles are available for free. Social media is not a bad reference if you know what you're reading. These are some infectious disease physicians that are highly trustworthy. These are their Twitter accounts. They post about infectious disease issues, but mostly about COVID-19. I encourage everyone to check social media, and I encourage everyone to voice their opinion because people read social media وفي كثير معلومات خاطئة سواء فيسبوك أو تويتر ف we have to engage with people. لازم نتابعهم وما في أنا برأيي يعني silence مش لازم نكون صامتين، لازم نتحدث ونوعي الناس بشكل مستمر. Finally, COVID-19 is a new disease with new studies emerging. It's very possible that information today may prove to be incorrect weeks or months. That's why we have to continue to follow the literature. وشكرا جزيلا لجميع عمال القطاع الطبي من في الأردن.
شكرا جزيلا Dr. Faris. I think this is very helpful. So if you only have like one drug that's most likely it seems that could be available in Germany, which is dexamethasone, do you think it's the only game-changing drug so far لمرضى COVID-19 who are symptomatic with hypoxia?
Yes, it's the only drug that have proven mortality without any doubt. And it's a cheap drug, actually. It's relatively cheap. Steroids are cheap and widely available. So Remdesivir, يعني احنا بأمريكا بنلاحظ سعره كثير مرتفع. No clear evidence of mortality benefit. ممكن يكون له فوائد people contagious ممكن مشاكل بالهوسبيتال بيدز ممكن الناس تطلع من المستشفى أبكر لكن it's not a game changer. It's not a game changer. It's not a magic bullet. مش زي
I think they should not feel bad that's not available in everything in Jordan. I don't think that we should think that we are lacking a treatment, at least at this moment, as a magic treatment.
Yeah, it's not a magic treatment وسعره غالي جدا. يعني الكورس ل5 أيام في أمريكا $3,100 وعم تحكي عن دواء ما بفيد. فأنا يعني طبعا this is a political decision يعني but if we don't have resources I would rather target other things like